So this chapter is it's a rather long chapter if y'all have looked over it, and we're gonna try to hit most of the main points. There's some stuff that we may briefly talk about but skim over. As far as the assessment goes and stuff like that, there's a good portion of this that's on assessment, and we'll talk about the key points that are specific to toxicology, but I'm not going over ABC, CAB, unresponsive, all that kind of stuff like in every chapter. So we're going to talk about exposures to toxins in many different ways. We're going to talk about chemicals. We're going to talk about ingestion, injection, and all that kind of stuff. But exposures to toxins is a very common emergency. And in a lot of cases, there's not a lot that we can do. There is way more toxins out there than there are antidotes for toxins. So we have to pretty much be able to recognize that they've been exposed. If it's a situation where we may be in danger, take care of ourselves and our partners, make sure that we're protected, and then stabilize symptomatic treatment and get them to the hospital. And what do I mean by symptomatic treatment?
You treat the symptoms.
Yeah, exactly. You treat symptoms, kind of like a common cold. There's no cure for the common cold. You just treat the coughing, or you treat the sore throat. 82% of toxins are unintentional, meaning accidental, right? If there's intentional poisoning, it's going to be one of two things. It's either I'm trying to kill myself or you're trying to kill me, right? Now, with that being said, there's a difference in an intentional exposure and an intentional overdose, right? I may expose myself to certain things to get high or to trip out, but I may not be intending to kill myself, right? A lot of your common substances are going to be prescribed medications, the good stuff, household materials, industrial materials, all that kind of stuff. In all cases, the main thing is if somebody's exposed, we got to figure out how they're exposed and figure out a way to decrease the chances of getting them to be exposed even more, or to decrease the chances of them absorbing that stuff, if they swallowed it or something like that. The main goal is to decrease absorption and get it out of the body, right? If it's a toxin, it needs to get out of the body. And then all this other stuff here can cause fatal exposures. And again, it's in a lot of cases with like your sedative hypnotics, your opioids, all that good stuff, it's not necessarily going to be that they were trying to kill themselves, but they just have had to take more and more and more to get high. And so they've accidentally done it. Now, what do you think pediatric population, what do you think is probably going to be the common exposures there?
Household cleaners.
Yeah, not putting that little white lock on the cabinet for under the sink.
They like to drink those little plug-in air fresheners.
Is that what's wrong with you?
No. Yeah, you're recording.
I know that, I forgot. They do anything that smells sweet or anything that looks interesting. They will put in their mouth. I was down at that class this weekend, and our instructor was telling us about a call. He worked at Mobile Fire. He was telling us about a call where a kid went unresponsive and just went limp, and he had gotten a hold of his grandmother's pill bottle of beta blockers, and they were red, bright red, and they looked like candy. I don't know of any candy that would taste like a medication, but he was just popping them in his mouth, chewing them up and swallowing them. So yeah, a lot of times they're going to be exposed to stuff that they get into. Toxicology, it's just the study of prescription and illegal drugs and any other way to become toxic. Plant, animals, any other toxins, synthetic toxins, anything. Now, within toxicology, there's specific categories, just like within pharmacology, there's specific categories of medications, there's specific categories of toxins, and these categories are called toxidromes. And these are just some toxidromes. You got your cholinergics, your anticholinergics, and your sympathomimetics. Your cholinergics are what's going to stimulate the parasympathetic nervous system. Your anticholinergics are what's going to work against the parasympathetic nervous system. And then your sympathomimetics are going to be what stimulates the sympathetic nervous system, and that's going to be what? What kind of things will stimulate the sympathetic nervous system?
Fear.
All right, fight or flight, but you're not going to overdose on fear. Yeah, stimulants, cocaine, ADHD medications, diet pills, things like that. The narcotics, they're going to be your opiates or opioids. They're going to bind to the receptors on the cells. And then extrapyramidal, and this is going to affect the extrapyramidal tracts of the nervous system, which are the nerves that go down and control motor. Most often these are found in antipsychotic medications. Did you talk about extrapyramidal effects in EMT class? Where somebody that takes like Haldol or antipsychotic medication, they'll develop these twitches and you know, have issues with that. Well, we'll talk about that here in just a little bit. There's 4 toxin routes, just like there's routes for medication. Just think medications. You got ingestion, inhalation, absorption, and injection. Just about the same routes that you take medications, right? Your inhaled toxins are going to be your fumes and gases, and they're going to cross over the respiratory mucosa, or they come in contact with the respiratory mucosa and can cross the respiratory membrane. What happens when it crosses the respiratory membrane? What's occurring at the crossover of the respiratory membrane? We just talked about it just a little while ago. What's occurring down there in alveoli? Gas exchange, right? So if you're inhaling these toxic fumes, that's going to kind of take the place of the oxygen, and it's going to offload that into the blood, and that's how it's going to start having the effects in the body. You follow me? You got the toxins that damage directly to the skin. This is going to be stuff that that is rubbed on, some creams, also things that causes rashes, poison oak, poison ivy, things like that. These are absorbed through the bloodstream that way. And then you've got your injected toxins, which are going to be your IV medications, your bee stings, snake bites, things like that. The effects of the toxins can be localized, systemic, or both. What would be a localized effect?
Just localized in one area.
Right. Yeah, y'all are both right. A bee sting here, and it's just going to be a whelp here. I'm not allergic to it. I'm just going to have issues on my arm. Or poison oak. I get exposed to poison oak, and as long as I'm not scratching and rubbing the rest of my body, it's going to say localized. Then systemic is going to be, you know, where it's going to affect the whole body. This is pretty important here because poison control is utilized very, very often in a pre-hospital and emergency department setting.
Who calls them in a case like that? Do we or
You can. Yep, you can. You can call them. if you haven't gotten the information and you get them to the hospital, they'll call them there. Because think of all the millions of different ways somebody can be exposed to stuff. Think about if you go to one of these industries down here off the interstate and they ingested some kind of chemical. I don't have a clue about any of that stuff, right? They've got a database of all this stuff. And the cool thing about poison control is the fact that it's not just for healthcare professionals, it's for the public as well. So the kid that may or may not have drinking a whole bottle of Pepto-Bismol, that's not a good example, you would know that. They may not have taken a pill or something like that. A scared mama can call and they can tell her what to look for, when to go to the doctor, all that kind of stuff. Does that make sense? Very easy to remember, 800-222-1222.
You have a song too.
1-800-222-1222.
Yep.
Remember that.
So we would utilize them in the pre-hospital setting if it's something that we don't know, but it may be something that they're having these weird effects on, and what else, do we need to be looking for, or what the typical treatment for this is. And of course, you may want to contact Med Control first, and then they will, they'll advise you what to do, whether to go ahead and call poison control or not. The cool thing about poison control is when they're activated, if that patient is admitted to the hospital, they follow up with that patient even after, all the way up to the point of release, and I believe they follow up with them even after they've been released. I have been in the ICU before. In the ICU, we get, if it's a patient that was a suicide attempt, but they're actually got a medical problem wrong as a result, they'll send them up to the ICU because we've got such a low patient load that we're able to keep our eyes on them. And I've been in the ICU where a patient came in and overdosed or poisoning, and poison control 24 hours later calls to check in on that patient to see if there was any changes or anything. And so, if I told them, hey, he had this really funky thing going on, they will record that, and that would probably go back into their data. So that's actually a pretty neat thing. So, toxins aren't just ingested. They're not just, just something that somebody poisons themselves with. I mean, we talk about toxins that can be on a hazmat level, right? The biggest, most important priority with any type of toxic exposure is to make sure you're not exposed, right? And you're going to do whatever it takes to not be exposed. And that's going to be with PPE. Do what?
So it doesn't really look like the appropriate kind of
No, they are, and it really depends. I mean, if it's an airborne thing, that an SCBA, an enclosed circuit breathing, can, help, then that would be okay. But now if it's something that you can get exposed all the way down to the core, to the bone, or to the skin, of course, turnout gear is not going to protect you from that. So you want to kind of have an idea of your scene. You want to do your scene size up, your windshield survey. Remember talking about the windshield survey and all that? We're looking at the scene before we even get out of the car, right? In some instances, we may be looking at the scene a quarter of a mile away, making a judgment call on what to do, right? But the problem with toxin exposure... Oh yeah, the thumb rule. The problem with toxic exposure is you may not know that somebody's been exposed to something until you get there. You may not know what's going on with the patient. It may be unclear. But one thing you can do is recognize patterns and recognize, typical things that you might see with the different types of toxic exposures. Always have your PPE PPE ready to put on. And of course, with every patient, you're going to use your standard precautions no matter what. Very important, the early identification of a hazard, even if it's not a mass casualty incident. If you've got patients that are unresponsive, respiratory distress issues, not breathing good, but still have a high O2 sat, and it's affected a whole family that's been sleeping, what are we thinking? CO, carbon monoxide, right? So we need to identify the fact that these patients have been exposed to this, and I could very well be exposed very quickly. So we need to early identification. You see what I'm saying here? You following me? See where I'm going with this? Cool.
Yes, ma'am.
Thanks, man. Your resources. Now this is important on when you do your National Registry assessment. If you notice on your assessment sheet, it doesn't say ALS backup anymore. That's one of the changes from your EMT. It says request additional resources or additional help. Now ALS may still be part of the additional help, but we're identifying the scene as a whole. We're identifying what's going on the scene and realizing what our limitations are and requesting the people that aren't limited, that have the resources and the training to handle these. What do you think law enforcement might have a hand in a toxic emergency? Control.
Keep people out of the area.
Yep. Scene control. But what about the patient? Those toxins may make them do some crazy stuff, right? Not that they know intentionally what they're doing or something, but you may need law enforcement there just to help you control the patient, right? And then, of course, fire, hazmat, all that kind of stuff. Other important things to look at when you're surveying toxicologic emergencies, is it just one patient or is it more than one patient? Because if it's a toxic issue and it's affecting more than one patient, that's probably going to be a warning sign that I need to be looking out for what it is that just made all these people fall out, right? Also, unusual odors or presence of vapors or spills. If I've got this little yellow fog hanging around the scene, I'm not going in, right? I'm waiting unless I'm trained and I've got the resources and all that. I mean, the guys at the fire department and stuff, y'all are trained in hazmat, so y'all got the equipment or the means, or at least you'll have somebody responding there, you know. If I'm just sitting on the ambulance with ETS, I'm there as a patient care provider, not a hazmat control. You see what I'm saying? And then, of course, their psyche, their behavior, if they're altered, if they're unresponsive. Identify the substances if at all possible. How much was involved? How long were they exposed? How much do they weigh? Why do you think a patient's weight might be important?
Less they weigh, the less they handle.
Exactly right. You know, if you compare me to a 90-pound woman, you know, she's not going to be able to process and absorb near as much as I will be able to. Also, they're going to ask that if you call poison control as well, how much do they weigh? So they can kind of give you an idea with that.
Like an aspirin, give it to a child.
Exactly. Exactly. And then also, this is very important. This is very important. What has been attempted in the treatment of the patient prior to your arrival? If, say you're at home, or say you get called to the home of a kid that's ingested something. Let's just say some laundry detergent or something. And grandma's keeping her. Grandma's from old school. what do you think Grandma's going to do to try to? She's probably going to either try to give her some milk or something to kind of buffer it out, or she's going to try to make her vomit it up. Serpivipicat. We don't want to induce vomiting on anything.
It can cause more damage coming up the esophagus
Exactly.
than it already caused going down.
Exactly.
We don't want to get it out of the system.
We do want to get it out of the system, but not that way. We're not going to get that out of the system.
You basically don't want repeated exposure on the same tissue.
Exactly. Think about it. If I swallow something harmful and it did damage coming out, now it's combined with that hydrochloric acid in my stomach. It's going to do a lot of damage coming back up. So we're going to possibly give them activated charcoal in certain situations, let them get to the hospital, and they're going to put a tube down their esophagus, and they're going to pump it out where it's not going to be exposed to their esophagus. Does that make sense? That's why you don't want to induce vomiting at all. And we don't have anything to induce vomiting. We don't have any kind of, medication to induce vomiting. But what I'm saying is that there's home remedies and there's things that folks may do to try to not just induce vomiting, but there may be other things that they may do. You need to find out if they've ingested anything else beside that poison, or if there was anything else done. Make sense? How long were they exposed? Because the longer they're exposed, the more problems they may have. Look at the label. Try to take the container of whatever it is, whether it's a pill bottle or some kind of medication or anything like that. Try to take it with you. There's a couple of things that can aid you in identification. If it's hazmat, and it's like out in on the street or something, we've got a truck with a hazmat spill or something like that. This emergency response guidebook would help. And I'll just let y'all look at it. You got it on your phone?
Yeah.
Just take a look at it. Good. Cool. Y'all are good. Y'all are more G's. See if I bring anything else up here for y'all.
I've got one. I've
Spent
got
a whole week
one
on
in my
it.
truck, but I like the one my phone does.
Spent a whole week in that little book.
Hazmat, you know.
Then what are material safety data sheets?
That's all the information and chemicals stored somewhere.
Right. It is a OSHA mandated thing. If you've got any kind of industry that falls under OSHA, everybody know what OSHA is?
Yeah.
If you got any kind of industry that falls under OSHA and they've got any kind of chemical, I mean down to the Clorox they use to clean the bathrooms, they have to have that stuff labeled, a printout sheet of it, and they have to have it stored, a hard paper copy. What?
I know Publix keeps theirs online. You have to access.
Do they?
Yeah,
You're
computer.
supposed to have a lot of copies.
Yeah, I'm pretty sure you're supposed to have a hard copy, but
Yeah.
maybe they've got them. Maybe they've got.
I think hard copy.
Maybe Publix has a hard copy at a central office that you could call and they could pull it or something like that.
Probably.
And then identify the potential for polysubstance overdose. What is polysubstance?
Full substance.
Yeah, simple as that. Is it one thing that's caused this, or is it a poly thing, a bunch of things? A lot of your toxins are going to affect your central nervous system, right? It's where you get the unresponsiveness or the behavioral issues or all that. It's because those toxins have hit the brain, hit the nerves, and they're going haywire. So we know that our primary assessment is to identify what? Think of your primary assessment on your assessment check sheet. After you get past seeing size up, what is your
General impression.
we're determining responsiveness and apparent life threats, right? AVPU and ABC, right? That's in your primary assessment, right? AVPU and ABC. So if they've got airway issues and they've been exposed to something, and as long as we know the scene's controlled and we're not being exposed, at that point, it doesn't necessarily matter what they've been exposed to if they're not breathing, right? Or if their heart stopped, as far as we go, as far as our skills go. Because we've got to maintain AVC before we can really start figuring out, oh, well, what's the antidote or what, this or that, right? This is what I was talking about, vomiting with exposure to many toxins. It jeopardizes the airways. It's not necessarily what I was just talking about, but a lot of times, the body has a natural way of trying to get rid of what's not supposed to be there, right? I mean, I guarantee you, if you tried to take a mouthful of bleach right now, your body is going to fight you very hard to swallow that stuff. And as a matter of fact, it's probably going to start forcing vomit out to try to get it out, right? A lot of these toxins can cause soft tissue damage of the upper airway, which you're going to have inflammation, and with inflammation comes swelling, and comes inadequate movement of the airways, right? Also, pulmonary edema. What would this be called? Pulmonary edema created by something other than the heart. Bingo. Always check your breath sounds. Always check your breath sounds because of that fact that a lot of these toxins can cause pulmonary edema. All right? You want to go ahead and identify early. That should be part of your ABCs. When you're assessing your breathing, you're listening to breath sounds. Okay? You follow me? Constantly reassess. They also can cause vasodilation. Some may even cause vasoconstriction. Nonetheless, if you've got something that's making your vessels constrict or expand that's not supposed to be taken, like blood pressure medication or something, the body's not going to adapt very well at first, and it's really going to decrease your cardiac output and your perfusion. And always looking at your airway. Be ready to do CPR. I'm going to move on past this. You'll know about all this stuff. Then your sample history. What information should you obtain about the exposure? What are some of the questions you need to ask?
Quantity, how much?
What would be the number one question that I'm going to be asking?
What is it?
Yeah, what is it? What is it? The number two question that I'm going to be asking is how much? How long? Have they ever been exposed to this before? Was there anybody else involved? All those kind of questions, right? And even if they have been exposed and they're altered mental status because of the exposure, let's go on and do a blood glucose. Sometimes it takes a while for these poisonings to take effect, for it to really start getting absorbed. So that's where it's very important, if a person's just acting funny, or if they're stable, let's get a good history, because that might give you a clue that this patient may be crashing here in just a little bit. Think about medications. It usually takes a good 30 to 45 minutes for a digested medication, a PO medication, to start working in the system, right? Suicide is a big issue with toxicology. That word, toxicologic emergencies. Most, well, no, I don't want to say most, but a lot of people will try to do suicide with several different methods. If they're planning on hurting themselves, they may take some medication so it don't hurt so bad. That kind of stuff. One of the big clues for a big situation is going to be the presence of more than one patient that's acting funny, right? I don't think I really need to hit on that a whole lot more. what do we need to give a person that's been inhaling toxic fumes? What do they need more than anything?
Oxygen and something.
All right, so they do need oxygen, but they need fresh air. They need to get out of that area, right? Because I can put oxygen on a patient and we still be in the house full of carbon monoxide. Carbon monoxide still has a higher affinity for hemoglobin. You see what I'm saying? These toxins, we've got to get them removed from that situation, which that should be a no-brainer because we're not going to take care of a patient in an area that's toxic. But rapid removing them. Your treatment, your general treatment for all toxicological emergencies, I'd have trouble with that word. ABCs as always. IV. A lot of your toxins may cause acidosis. We want to give fluids, not just for acidosis, but we want to give fluids maybe to start trying to flush some of that stuff out of the system as well. And we want to minimize the amount of toxin the patient's being exposed to. How would we do that? What's an example of how we would minimize it? Get them out. Get them out of the situation, right? Or give them medication to keep them from absorbing it more. All right? We'll talk about that. Most toxins don't have antidotes. The ones that do have antidotes are few and far between. So that's why it's very important to identify them early. We'll talk about Narcan again in just a little bit. Well, with narcotic overdoses, we know that we give Narcan, right? What is our dosage of Narcan? 1 to 2 milligrams. How? Route.
This
IV, right. Activated charcoal, and again, we may not do it in this area by our protocols anymore, but this is a National Registry drug, so we need to know it. If you go work in Georgia, they may allow you to do that. It's an adsorbent, not an absorbent, but an adsorbent. All right? Just keep that in your mind for just a minute. Adsorbent. It needs to be given within 1 to 2 hours after ingestion because if we go longer than that, there's probably not going to be in the stomach, right? And it's pre-mixed in a slurry. That bottle is pre-mixed and they've got a little bit of sugar alcohol in it that adds flavor. Keeps them from completely throwing it up. All right?
A poison is any substance that can harm the body, sometimes seriously enough to create a medical emergency. Once on or in the body, a poison may act as a corrosive or irritant, destroying skin and other body tissues. A poisonous gas can act as a suffocating agent. Systemic poisons harm the entire body or specific organ systems. Commonly, poisons act on the central nervous system to depress or overstimulate the brain. Activated charcoal is used in cases of ingested poisons and works through adsorption, the process of one substance becoming attached to the surface of another. Ordinary charcoal adsorbs some substances, but activated charcoal is different because it has been manufactured to have many cracks and crevices. By ingesting activated charcoal, the poisons bind to the increased surface area and are eliminated by the body.
Alright, so you get what he's saying there? If it was absorption, the charcoal would just absorb it in as its own. Adsorption means that it's not taking it in to the charcoal, it's binding to the charcoal on the outside. And what the charcoal does is it just helps it, it speeds up the process of getting it out. It kind of just grabs all of those molecules in one area on that charcoal and then it pushes it on out. You see what I'm saying? Follow me? Yes, ma'am. Thanks. And then, of course, contact poison control. This is just an example of charcoal. Y'all seen it. I've got some. I think I've got some down in the drug box.
There it is.
Why do you want to reassess? Right, every 5. If it's not critical, it's every 15. But you want to see if they've changed from their baseline. You want to see how they were in the beginning and how they either digressed or progressed, right? The thing about toxins is that it's like I said just a few minutes ago. Some of these toxins may not start really acting until a lot longer later than first absorbed, right? So we need to be prepared, and that's why we're going to continually assess. Narcotics are going to cause, overdoses of narcotics are going to cause unresponsiveness and respiratory depression. We've got to manage that airway carefully. Giving Narcan or naloxone doesn't affect the airway directly, but it affects the airway by doing what?
It binds to
Binds to the nervous cells and knocks the opiates off, and then they can start controlling the body normally again, right? We're going to talk about that in a little bit more in just a little while. Now, if we give Narcan and they've got like a oral pharyngeal airway in, and we start waking them up, they may start gagging, and they may start, thrashing around trying to get it out. We need to be prepared to suction. If they get to the point to where they're breathing real good over your bagging, if you're having a lot of issues bagging and all that, and their mental status is coming around, you need to go ahead and pull that out, because that's going to cause a lot of irritation, all right? But if they come around just a little bit, enough for them to start gagging and all that, but they're still not awake, you need to be suctioning, all right? Because if they're not completely awake, they're probably not going to be able to maintain that airway, right? We're going to talk about that a little bit more here in just a little bit. Y'all good? Y'all need a break? All right, let's keep going. Carbon monoxide, CO. Colorless and odorless. That's why so many families get poisoned by carbon monoxide with faulty furnaces and things like that, because they never know. They never know. New homes, it's a law that they have to have carbon monoxide detectors put in their homes when they're building new homes and stuff like that. Older homes may not have it, and older homes are usually going to be the ones that are going to have the biggest issue, right? Also, carbon monoxide, who would be the biggest group of people exposed to carbon monoxide besides families sitting at home? Firefighters. Because it's created during the combustion of fuels, a house fire, or all these other nasty things burning. It's in smoke. Yes, sir.
Don't most fire departments offer carbon monoxide detectors and stuff?
I know that they will check them for free and all that. I don't think that they give them away for free, but I know that they'll come into your home. At least Oklahoma did. We could go into people's homes. Our fire inspector would go into the homes and check them. But sometimes they may do like public safety drives or something like that, promotions, and give them away. But I don't think they. I know that Opelika, we didn't just keep carbon monoxide detectors in the fire department. Do y'all? Carbon monoxide, obviously, is dangerous in enclosed spaces. What does carbon monoxide do? Yeah. Carbon monoxide and hemoglobin have a love affair. There's like no other. They're just so in love. And even though hemoglobin and oxygen are married, when carbon monoxide comes along, they drop off that oxygen and say, "Come on, baby, let's go." What does a pulse ox register? What does it read? It just measures the saturation of whatever molecules on the hemoglobin, right? it doesn't differentiate between an oxygen molecule and a carbon monoxide molecule. So, if carbon monoxide is attached to the hemoglobin, and that hemoglobin is saturated full of carbon monoxide, what's the pulse ox going to read? 100%. But are they going to be sitting here like they're legitimately 100% oxygen saturated? Absolutely not. Scene size up, history, questioning, patient appearance, clinical appearance, right?
With that, capnometry, would anything like that indicate anything if they were, would that tell us anything?
That's for carbon dioxide.
So,
That's for carbon dioxide. So no, it would not. So we just talked about it. Poor oxygen carrying capacity causes cellular hypoxia. It blocks the cells from getting oxygen. You can be breathing in all the oxygen you want, giving them 100% oxygen, but it's got that block up there, and it's going for a ride on the hemoglobin, and the oxygen is just left in the lung sac. Most common early on is going to be headache and dizziness, then followed by confusion. Sleepiness is really bad. Once they start getting real sleepy and all that, why do you think they're getting sleepy? Why do you think they're having any of this stuff?
The brain's not getting the oxygen.
Exactly right. And then, of course, vomiting as well. Shortness of breath. All the things that you would typically see with hypoxia. Severe poisoning. I don't remember what I left blank and what I didn't leave blank on y'all's things. So if I need to hold up for a minute, let me know. Severe poisoning. Confusion. Ataxia. What is ataxia?
Immobile.
Unable to walk, right? Seizures. Unconsciousness. Rhabdomyolysis. And renal failure. That's prolonged exposure. And then, of course, death.
What's that rhabdomyolysis? I forgot. What's that?
Yeah, rhabdo is a, let's see, trying to think about the best way to describe it.
I mean,
Yeah, let's come back. I can't think of it right off the top of my head right now. Let's see. So it looks like I know what I was talking about. Yeah, it's a breakdown of the skeletal muscle, and then when skeletal muscle breaks down, it creates toxins. And then those toxins start circulating within the body, and it causes a lot of really bad issues. I don't know why I couldn't think about that. Some common symptoms: headache, nausea, dizziness, breathlessness, collapse, and then loss of consciousness. I found another picture that had this on it, and the title of it said, what did it say? It said, effects of carbon monoxide poisoning or a good night out drinking. Because it's going to be a lot of the same stuff as somebody that's severely intoxicated, right?
About the first four are very good.
Yeah.
Always.
Always.
After a house fire, anyway.
Yeah.
You've got a bad headache and you feel sick.
Oh yeah, definitely. Always manage your airway, anticipate vomiting. All patients exposed to carbon monoxide need a non-rebreather mask. Number one, because we're not going to have a adequate oxygen saturation. Number two, we know that we're going to have a very low oxygen saturation, right? Number three, We need 100% oxygen to try to compete with that carbon monoxide to try to fight it off and get it out of the system.
Would a sleep pad be any good in this situation?
If they've gotten to the point to where they've got non-cardiogenic pulmonary edema, that might. But if they're breathing on their own and all that, just oxygen, you know,
But if they've gotten to that point, there would be,
they would.
respiratory-
You're right. You're right. They would need positive pressure ventilation. Yeah, you're right. High flow oxygen can reduce half-life, and also hyperbaric oxygen therapy. What is that? Hyperbaric oxygen therapy.
That would
Oh,
be that
that's
high
for-
pressure, like,
Yeah, that's like pressure.
Yeah, it's the compression chamber, the high pressure chamber where they put them in that little tube. Also diving, they do that, and it's kind of for the same reason with diving. But I think that's carbon dioxide more than it is carbon monoxide. Also, start IV and then fluid administration. Most important actions in the management of a poisoned patient. Figure out what it is. Are we safe? Are they breathing? Is their circulation good? And I need to get them out, or I need to give them something to keep them from being exposed anymore. Cyanide. Cyanide is very, very, very deadly, very bad. It's also found in several common products, including to, and not limited to, apricot pits and peach pits. Very prevalent in house fires. Very prevalent. Combines also with carbon monoxide. It is a cellular asphyxiant, which means that it cuts the oxygen off, it stops energy production, it keeps the cell from from processing the oxygen. Doesn't necessarily mean that it's not like carbon monoxide in the fact that it inhibits the transport of oxygen, but it kind of sets up a wall between the blood cell and the cell, right? This is why it's so bad. Death occurs in seconds to minutes.
Dang.
The almonds have nothing to do with it other than the fact that they say it smells like bitter almonds.
Oh, is that what it is?
Yeah. They're not in
Smells like
almonds.
bitter almonds?
That's what
Bitter almonds.
that's what they say. I've never smelled cyanide, so I don't know. But
I've smelled bitter almonds, it's not, I've tasted it, it's not.
yeah.
Basically smell like you're already dead. So,
I would probably
that's
think
another thing.
close to it. All these common symptoms here, not going to go through them all, but the pulse oximetry may be high. But it's not the same reason why carbon monoxide and carbon monoxide poisoning, the O2 sat may be high. Why do you think it may still read 100% saturated, but they still be hypoxic? Remember, it's putting up that block between the red blood cell and the cell. So cyanide doesn't inhibit the transport of oxygen throughout the body. So I can put a person that's poisoned with cyanide on 100% oxygen, and their cells may, or their red blood cells maybe, their hemoglobin may be saturated 100%. But once the hemoglobin gets to the body cell, the cyanide is there, and it's blocking the oxygen to go into the cyanide. I mean, into the body cell. See what I'm saying? Signs and symptoms reflect hypoxia and acidosis because that's exactly what it's going to be. They're going to become hypoxic and they're going to become acidic, right? When you become hypoxic, prolonged inadequate perfusion, you become acidic. Because the body starts breaking down, you start having all this acid production. High flow oxygen, also severe dyspnea and pulmonary edema. If it was ingested, activated charcoal will work with it. The antidote, cyanide has an antidote, which is hydroxycobalamin. It converts the cyanide into vitamin B12.
That's pretty low.
And that's just a picture. I guess y'all knew that was just a picture, right? So with these two, cyanide and carbon monoxide, one of our target people, or one of the, not target, but one of the main populations is going to be firefighters and rehab of firefighters.
Who would have this antidote kit?
Fire department carry, that's about it. If they
We don't even carry
No,
them.
we didn't carry it. It would probably be in the hospital.
Yeah.
I would imagine it's pretty expensive.
yeah.
But look for the subtle signs and symptoms. But have that in your mind if you're at a standby for a house fire. Be looking for all the things, CNS changes and the breathing changes and stuff like that. All right. Getting on into caustic substances. Do y'all need a break? Keep going. We'll get through the caustic stuff real quick. Caustic substances are alkalis and acids. They cause chemical burns. When they contact the body, they also do severe damage to the respiratory system. Same way you may be exposed to anything else. Often household chemicals containing acids or alkalis are ingested in attempted suicide. What are some examples of caustic household?
Clog.
Yeah, Drano. Drano is an alkali, isn't it? Even stuff like Clorox.
You mix Clorox with, there's a couple of them mixed, it's really
It's,
toxic.
bleach
Yeah.
and ammonia.
Bleach and ammonia, definitely.
That's
If you put Drano on
Aluminum.
aluminum, it explodes.
It's cool.
The difference in the burns, there is a difference in the burns between acids and alkalis. Acids cause coagulation necrosis. If they ingest a lot of acids, they're going to have metabolic acidosis as well. And then alkalis cause somebody say that for me. Liquefaction necrosis. Or liquefaction necrosis. So basically they're both bad. They're both very bad.
What's the picture on the right? Is that like the back of the foot or something?
Yep, that's the back of the foot.
Wow.
Trying to get to the chapter there. The liquefaction, that word necrosis. Basically, what it does is it just liquefies the body tissues, and then the other one, the acid burns. The coagulation necrosis, it's just a really, really bad burn that goes down to the core. Both will go down to the core. Watch out for your scene safety. Don't expose. If somebody has been exposed to an acid or an alkali in a solid form, and it's got on their clothing and all that, they've got to remove their clothes. They've got to remove them, because they're going to continue to expose anybody that comes in contact with them, and you don't want that junk on your ambulance, right? What is the pretty much universal diluent besides some? The universal diluent.
Water.
Water. flushed with copious amounts when it's exposed to the skin and the eyes. You just want to flush. Just try to get whatever you can. Now, say for instance, you go to the chemistry lab over in Auburn, and somebody's been exposed to something that's god-awful unknown, and that chemistry professor says, well, I've got the antidote, or I've got something that will react and stabilize that. Do y'all want to pour that on them?
No.
Absolutely not. Because it's going to cause a chemical process that's going to probably burn them even more. Water. Unless it's the rare few chemicals, which I can't even think of off the top of my head, that may react with water.
Like
I know.
sodium?
What?
Like sodium?
Sodium?
Yeah. Straight sodium will,
Will it? I know magnesium will. The old VW Bugs from the 70s, their motor blocks were made from magnesium. And when you'd have a fire and start spraying water on them, it would actually look like fireworks.
I think lithium reacts.
It may. Activated charcoal is not indicated. It's not going to bind with it. You need to get in touch with poison control. You need to find out what they have been exposed to. If they have swallowed a poison or an acid or an alkali, that airway is going to be very complicated. Because if it does it to the skin, which is tough, what do you think it's going to do to the very delicate tissues in the trachea?
Eat through it.
There's a lot of concentrated acids and alkalis that are used in industrial settings that we'll have absolutely no clue about, right? So those MSDSs are very important. All right, let's take a quick break. The next thing is hydrocarbons. Hydrocarbons are found in petroleum products, gas, things like that. But they're also in aerosol. This is just an example of huffing. Huffing is just where they inhale these fumes, these concentrated fumes that are in aerosol cans. We'll talk about that in just a little bit. All these petroleum-based products are in hydrocarbons. Common household things, lighter fluids, stain removers, glues, paints, and the aerosol propellants, the things that make your cans of aerosol spray. Exposure can occur through any route, and then the huffing is the cheap high. It's these people that huff air freshener or huff spray paint. It's the cheap high. One of the most popular things is the cans of air, the compressed air that you clean your computers off with and stuff like that. Do what?
Don't they do it with whipped cream? Like
Yeah, whipped cream.
Yep. Which I guess if you're going to get high, you might as well get high while it's sweet, huh? It's very toxic, but sometimes it may not be toxic to the point to where they're going to need intervention. Right. I mean, anything that you're huffing that's in spray paint or anything like that is going to be toxic. You're killing a brain cell or two every time you're doing that. Common things that you would see with the nervous system: dizziness, confusion, ataxia, hypotension, sudden cardiac arrest. Sudden cardiac arrest occurs because these hydrocarbons get in and they start interacting with the catecholamines, which is epinephrine, norepinephrine. And basically, it sends the heart into overdrive and it starts fibrillating the heart, and then the heart's kaput. It's gone. Nausea, vomiting, exposure to the skin, Liquid forms of hydrocarbons, high risk of aspiration. Why? What would be one of the reasons why, if you're trying to drink it, why might you aspirate it? Because the body says, heck no, I don't want this junk in me. And it starts pushing it out. And when it starts forcing it out, it may start going back down, except down the wrong tube. And then when it gets into the lungs, that's all she wrote. This guy's looking like he's having a good time with that spray paint can.
Double fist in it.
Yeah, he's double fisting. Yeah, that's right. Joker takes him a sip of paint thinner and then snorts a little spray paint. So obviously, you could think that it's going to affect a lot of areas in the brain and in the body, right? This guy right up here, this was a real patient that you see all the paint around his mouth and on his hands and all that kind of stuff. That may give you a very good indication that they've been huffing paint, right? And that's one of your assessment findings. Erythema and dried paint may be present around the mouth and nose.
What's erythema?
Redness. Sudden sniffing death syndrome. Basically, it works, like I said, with those catecholamines. It interacts with the catecholamines. It also sensitizes the myocardium, or it weakens the myocardium. And then once it starts getting that influx of epinephrine, norepinephrine, it's just going to make it go crazy. I can think of several situations that I've been in where I thought I was going to have sudden sniffing death syndrome. You just be around the fire department for any amount of time. Commonly abused substances: gasoline, kerosene, spray paint, paint thinner, gun cleaner, and all that good stuff. Organophosphates found in pesticides was not bioterrorism, but biowarfare back in Nam, the old Agent Orange. Very, very bad. Still found in pesticides, still found in big crop stuff, even in your smaller bottles. Organophosphates are cholinergics. What did I say cholinergics stimulate?
The parasympathetic.
The parasympathetic. Way to wake up, Kyle. The parasympathetic nervous system. It was right here the whole time. So when you have stimulation of the parasympathetic nervous system or cholinergic effects, you have sludge, salivation, lacrimation, urination, defecation, gastric distress, and emesis. Sludge. That, my friends, will be a test question. And if you don't know sludge by now, we're missing the mark somewhere, because sludge is something important. Not that you may not ever see it, but it's something that's important as far as testing goes, at the very least. But what is common about all this stuff?
It's all getting something out of the body.
Yeah. It's all expelling fluids, right?
I had a brain fart. What was it? Oh, yeah. Brain fart.
Organophosphate poisoning, you may see all the things that you see here. Twitching, paralysis, CNS stuff, respiratory issues. What? Oh, I thought I heard somebody say something. Again, same scene safety stuff. Decontaminate the patient. Water and soap. Soap is okay for organophosphates. It's going to be probably complicated airway management, right? Because if they're if they're vomiting, they're probably also going to be coughing up junk from their lungs as well, and then excessive salivation. You're going to have a lot of issues with fluid, so you've got to be prepared to suction. The antidote, and all ambulances are required to have this. It's called a Mark I kit. And it actually may have other names as well, but it's atropine and pralidoxamine. These antidote kits are not for the patient. They're for us. The patient's already been exposed. If we become exposed, we need to reverse that exposure so that we can continue to take care of that patient. Does that make sense? And it's in a pre-filled auto-injector. And it's numbered what to give first and what to give second. The atropine's first, and then the pralidoxime is second. The atropine is an anticholinergic. So it's going to dry everything up, right? That's the goal at least, right? We're going to try to dry everything up. The cholinergic makes you spew everything. The anticholinergic is going to work against that. There's an old saying that I learned in school that goes with anticholinergics. It goes, can't see, can't pee, can't spit, can't poop. Because it dries everything up. This is just talking about when sarin gas was used to poison people as a bioterrorism. It's a nerve agent. Chemical weapons, chemical warfare is still prevalent. I mean, at any time, that stuff could break out. I guarantee you, I don't mean to get into conspiracy theories, but there's a lot of stuff we don't know. Alcohol. You got ethanol, which is your drinking alcohol, and then you've got other forms of alcohol that are toxic. And even ethanol is toxic in excess. It's a CNS depressant. You know what happens when you drink alcohol. I'm not going over all that. What is this nystagmus? It's involuntary motion of the eyes that twitch back and forth. Somebody with severe alcohol intoxication or alcohol poisoning, lots of throwing up, respiratory depression because the CNS is so profoundly depressed. Very bad. However, don't always assume that a person's acting drunk is drunk, right? I mean, that's a very good example of somebody that's low blood sugar. Exactly right. They don't really care that they're injured. They don't really feel pain if they're drunk, you know. So we need to be looking out for any kind of injuries and then check your BG. Long-term effects of alcohol is bad. Long-term effects of alcohol abuse is bad. There's this Wernicke-Korsakoff syndrome, which is an alcohol-related psychosis. It's a combination of thiamine deficiency and also permanent neuro damage. There's a lot of damage that can be done. There's a lot of damage that can be done from chronic alcohol exposure. Amnesia and confabulate are part of this. What is amnesia? Amnesia, you forget. That's right. What is confabulate?
Or to make something false.
It's producing something that you have no recollection of, but you're making it real to yourself. I forgot what happened last night. I'm producing in my mind what happened, even though I don't know what happened. Does that make sense? All these other things really affects the guts and the organs in the abdomen, especially the pancreas. What's the most common organ we think about that's affected with alcohol?
The liver.
The liver, cirrhosis. Also, if any of y'all drink a lot of alcohol, testicular atrophy and feminizing characteristics.
So funny.
You don't think of that.
Obviously, it's going to be hard to reason with these kind of patients, but you got to try to verbally calm them down. It's very important because they can be dangerous very quickly. DTs. What does DTs cause from?
Withdrawal.
Withdrawal. Old man Joe has been drinking for 50 years. Finally gets tired of hearing the nagging of his wife 50 years later. Says, all right, I'm going to put it down. Cold turkey, quits drinking. 2 to 3 days later, that joker is off the chain. He's in a whole new world, a whole nother dimension.
You see that very often?
All the time. All the time.
That's the most dangerous withdrawal.
Hmm?
It's one of the most dangerous withdrawals.
Do you recognize what it is when you see it?
Oh yeah. Oh yeah.
Why, what do you get a history?
That history, they're going to be,
Can they reduce your dependence on alcohol over time?
yeah, and there's medications that they can take as well. They can help them. But they can
So if you see somebody in
Way down.
the field like that.
history,
Basically,
the history, but also they're going to be unresponsive, not unresponsive, but they're going to be altered mental status. They're going to be combative. They're going to be fighting. They're going to be just talking out of their head. Obviously, it's going to be a situation where they're not of this world, and it can actually kill them if it's not in a controlled setting. We get,
how would you differentiate that between like something else?
I mean, your treatment's going to be the same for anybody that's acting like that, right? I mean, we might give them Thiamine if they tell us that they've got a history of alcoholism or whatever, but if anybody's acting combative or whatever, treatment's going to be the same, possible restraints, managing airway, and all that kind of stuff, right? So, but we get them all the time in the unit because, again, we're a 2-to-1 ratio up there. I have 2 patients to 1 nurse, and so I can keep an eye on a person that's going through DTs a lot easier than somebody that's got 6 patients can. And all of our, y'all seen the doors in the ICU, you can keep an eye on somebody at all times. But it's crazy because we know if they come in, even if it's for a surgery or something, they're not going to get, they may get alcohol in the hospital. They may give them a beer a day, or a beer with lunch and a beer with dinner. The doctor can prescribe that, and we'll give them a can of whatever the pharmacy bought that was cheap beer. If they're dependent on like whiskey or something, we'll give them whatever cheap whiskey that they bought.
Right.
Yep, yep. But
Why, so they don't get combative and all that?
right, so they don't start going through DTs because it's very dangerous to the body to do that. But you know, sometimes they won't, and then these patients will come in, and when we're getting them in, they're not there for this. They're there for a medical emergency, and we start getting that history, and they tell us, yeah, I drink about a case a day. We know that in 2 or 3 days that they're going to start going off the chain. And then it lasts for 2 or 3 days. And then you may go in there 1 minute and they're off the chain and all that. You may go in there the next minute and they're awake and talking to you, and then it's over. If they make it through like that. I mean, but it's very dangerous in the process. Because it really affects the brain. And again, alcohol is CNS. You're going to see a lot of issues with the CNS. Alcoholics are preoccupied with obtaining and using alcohol. We go into that because of what we're going to talk about in just a few minutes. Toxic alcohols. Methanol, which is wood alcohol, bad. But it's sometimes illegally produced. I think it might be in some very crude forms of moonshine.
It's actually also, it's just cheaper to buy than drinking alcohol.
Yep. Alcoholics going to drink alcohol whatever way they can. My buddy used to work at down here at this Winn-Dixie, and he said that they had one lady who was a bad alcoholic. She would come in and buy a $2 bottle of strawberry extract about once every 2 days or so, and she would drink that because it had alcohol in it. NyQuil, not NyQuil, Sudafed, doesn't it have alcohol in it?
Sudafed's limited sales though.
Yeah, it is, but still, they can get a hold of it, in a home or something like that. But, any alcoholic, cough medications contain alcohol, and if they chug those, mouthwash, Listerine, this is going to mess you up. Blindness, altered mental status, ABCs, IV, fluids. You want to try to maintain renal perfusion, and that's by fluids, keeping good blood pressure. Isopropanol, what we use to clean arms whenever we start IVs. Disinfectant. Rubbing alcohol. If they drink this, twice as drunk, twice as sick, twice as long. All these issues you see here. Ethylene glycol is antifreeze. I haven't tasted antifreeze in a while, but I know that they say it used to have a real sweet taste. I know that it's been a very common undetectable form of pet murder.
We ran a call one time to a lady that drank almost a gallon of antifreeze.
I don't see how. It's crazy. It's bad though. It's legal in small amounts. And, if antifreeze smells sweet, so I would imagine it would have some type of sweet. It wouldn't be good.
I know most vehicles take a different kind of antifreeze.
Yeah, that's what I was going to say. I think that they've started changing the production ways of some of the antifreeze and stuff so that it doesn't have that sweet taste. Anyways, airway, manage vomiting, watch for respiratory depression. Kids are going to be curious. Those are most often the the factors in them being overdosed. Not being watched very closely, but heck, you can't be judgmental of a parent that's got the 2-year-old that's just running around in every single thing when they try to keep their eyes on them, because sometimes they'll get stuff and pop it in their mouth before you even realize it, before you even know they had access to it. Not on the same degree, but heck, me and my little girl Sunday afternoon when I got home from Mobile, we walked outside. I was letting her play in her little pool and all that, and walked down to my garden. She walked down there with me, and I was looking at the cucumbers. She was looking at them with me. Next thing I know, she's pulled 2 of my tomatoes off the tomato plants, and I didn't even realize. Kids can get into stuff very quickly, very easily. And then factors with geriatric is polypharmacy, depression, all this kind of stuff. Food toxins. We're going to go over these quickly. Botulism. We've heard of botulism before. It's an infectious disease. Also seafood. Some contain toxins. This one, Ciguatera, it's in seafood. Obviously, if you ingest something, you're going to have a lot of GI issues if it's toxic. Also, some, like botulism and stuff, is going to have neuro effects as well. Paresthesias, reversals of heightened cold, tooth pain, weakness, all that stuff. Histamine fish poisoning. They eat the fish, and it releases tons of histamine in the body. What is another thing that releases tons of histamine in the body? Allergies. Mimic signs and symptoms of allergic reaction. So if it mimics the signs and symptoms of allergic reaction, what could be symptomatic treatment for it?
You can treat the symptoms of an allergy. You can
Yep.
give them
Antihistamines, epi, Benadryl, albuterol if they're wheezing. Affected fish that have some of these toxins can have an off flavor. If I ever eat fish and it tastes off, I'm not going to continue to eat it. I'm going to spit it out. I'm not going to swallow a fish that tastes off. That fish needs to taste like fish, or else I'm not eating it.
All.
Yeah. Yeah. Also, hypotension, bronchospasm, and angioedema. What is angioedema?
It's localized swelling.
Yep, you see it a lot in the upper airway, starting at the larynx, and you see the lips get real big, and the tongue swell up real big, and that's bad. Angioedema is bad. ABCs, fluids. What's the nebulized beta-2 agonist? Albuterol. And then antihistamines. Plant toxins. The shrooms. Also, your poisonous dermal exposure plants. Found everywhere. Cyanide, we talked about it, it's in the peach pits. All these others, I'm not going to just sit here and read them, but you can see them. The colchicine, amygdalin, calcium oxalate, the belladonna alkaloids comes from Jimson weed. What medication, and y'all probably don't know, but there's medication that is made by the belladonna plant. It's atropine. See some of the signs and symptoms here? So if they've been exposed to this plant, they may have a lot of anticholinergic effects. Glycosides. We give medications called cardiac glycosides that affect the heart rate, the heart rhythm. They're from the purple foxglove plant. And you'll hear that again when you get into paramedic school. And solanine is from the potato plant and also the green parts of a potato. I've always heard that if a potato is green, you get it out. It's very, very poisonous. Like a potato that's been sitting, grown eyes, and turned green. You know, if it has eyes, it's okay to eat. But once it starts turning green, you want to throw it out.
I didn't know that.
The Jimson weed has anticholinergic effects. We know what we'll look for. Anticholinergic, toxidrome, any of the things that are in the anticholinergic category. Mad as a hatter, dry as a bone, red as a beet, blind as a bat, and hot as hell. And that's just symptoms. This is some mushrooms. You don't want to just eat wild mushrooms. Unless you're Mario. Everybody please take a look at my board and laugh at my joke. Thank you. Thank you.
It really was fun.
Is that representative of you?
No. I did like to play Mario.
Mario 3 was still have the original.
A lot of these medications contain those cardiac glycosides like we talked about. Don't want to eat just any wild mushrooms. You want to make sure that they're cooked. You know, it ain't good. I'm not going to test real high on all this stuff here. Basically, it's all going to be supportive treatment no matter what. The biggest thing I'm going to say is if they have been exposed to something, it doesn't matter what it is, try to bring evidence of what they've been exposed to. Now, I don't know why you would be called to emergency poison ivy exposure, but you know, if it's the belladonna plant or whatever, you know, take a digital photo of it if you can't bring it, and that's really with any kind of poison.
Well, if somebody's burning poison ivy and they inhaled it,
That may,
it could affect their airway.
yeah, might could. Venom. Localized discomfort with most venomous insects. Believe it or not, there's very few venomous plants and animals that will kill, or insects and animals that will kill you. But there's a whole bunch of them that's going to make you have a really bad day. In most cases, they'll be able to say, hey, I got bit by a rattlesnake, or that one won't kill you. Or, hey, I got stung by a bee, or something like that. Big infection risk with animal bites for sure. That old dog with old nasty mouth that's been licking his behind comes over and bites you.
That's actually cleaner than kissing somebody. Doesn't let the dog lick in your mouth.
If a dog just went and licked his behind and has boo-boo in his mouth and he bites you, you are going to get an infection.
That's what they say.
I don't care what they say.
Dude, I got bit right there.
And even if it's cleaner than that, I'm going to kiss my wife over my dog any day of the week.
What if your wife kissed a dog and then tried to kiss you?
I mean, I can't say because we're recording, Dusty. We're going to take a quick look at the venomous spiders, especially the ones that are around this area. The old fiddleback, the old brown recluse. Don't see a whole lot of them. Doesn't mean they're not there. It's just that they're recluses, right? They hide.
I don't think I'm going to get close enough to see if they got
I'm going to do my best not to. Common characteristic is that fiddleback on their back. A little shape of like a fiddle. Now this one I have seen a buttload of them.
That's one of my laundry.
Oh, yeah.
I've seen them in spring of this year.
See him over there?
At one time, I found 3 or 4 black widow spider webs at one time on my front porch, and I sat out there and waited for them to come out and killed every one of them. But you know, characteristic is the hourglass red or orange on the back. This is just the localized brown recluse bite, 24 hours. Doesn't look more than a bug bite. Might have a little bit of erythema around it. Starts getting bad, the venom is spreading. And then it gets so bad they actually have to go in and debride it. Take all that dead tissue out.
Dang.
This is another example with necrotic tissue all around the hand and all that. Bad. The bad thing about a brown recluse is that you may not, and I think even with a black widow, you may not even know that you've been bit.
I've been bit before, you don't even notice my brown blue.
You've been bit by a brown recluse?
You don't even, I can't even feel it, but it's not really.
Right.
Feels like a mosquito bite on
Did it get real bad?
it. Got swallowed up real bad.
Yeah.
Probably
Yeah,
did.
it was nice.
Yeah, much.
Yeah, probably not.
Not.
With a brown recluse, a lot of times they may get it, you know, you leave your shoes out in the garage, and they done found them a new home, you know. I've started checking my shoes every single time, like my grass cutting shoes and stuff, or your fire boots or whatever, you know. But the thing about it is that if you've been bit by a brown recluse or even a black widow, give it a little time. You're going to know. And then eventually it's going to cause substantial necrosis if it's not treated. The black widow injects some potent neurotoxins, which will affect the neurotract. Only the female bites, though, are dangerous.
Female of a black widow?
Mm-hmm. They're the dominant one of that species. They'll mate with that male, and then they'll bite his head off and kill him.
Aren't they the only ones
I don't know. I think you're right, but I don't know for sure. Scorpions, common in southwest states. There's only one scorpion that causes fatalities. Most of them hurt, though. I have been stung by one of those little scorpions that are around the lakes and stuff here, and they're pretty painful.
Like a wasp, like that.
Yeah, yeah. It's
Did
I've
the male,
found them on both
is
of
about
them.
the size of the female, and it may or may not have valid legs.
One time, I walked out of my house last year during this time when we started having a lot of black widows show up. I walked out of my house, looked. I've got like a stone, like it's like stone decoration around half of my house in the front, and I looked, and there was a black widow spider web with a black widow hanging there, and it had a scorpion caught in it and was about to kill the scorpion and eat it. It was crazy, crazy. Anyways, it's neurotoxic, the venom is. Same thing that most neurotoxins will cause. On this one, you may want to apply a loose constricting band above the site to slow the distribution of the toxin. But you don't want to tourniquet it, all right, but it'll help slow it.
From having it come into the body.
Right.
Just maybe put like,
Yeah. So if they got, say they got stung on their foot, you may want to put a light constricting band just above the ankle.
what kind of band that you would use for blood pressure,
IV stick.
for an IV stick,
Yeah.
something like that.
Yeah. Do what?
Look like a constricting band or a soda pulse and raise the pulse pressure.
Well, again, you're not going to put it on to really
Oh, no,
include anything. So it may, but I doubt it. I mean, I doubt you're going to have a lot of effects. The body's going to compensate for that fairly well. Really quick, the non-poisonous states. These little sissy snakes over here. Then you've got your pit vipers. See them a lot around here. And then the coral snake.
Isn't there a saying about there's
Yellow,
another snake that looks
black
just
on
like a
yellow,
coral snake?
Yeah.
is a good fellow.
Yep, I'll show it to you in just a minute.
It's black on red.
Pit vipers, characteristic. They got the pit under their nostril there with the vertical eye slit. A lot of times they're gonna have the diamond back in the triangle head. They're also going to let you know they're there too, which is really nice of them. Common symptoms of a snake bite. I mean, it's going to be a lot of the same signs and symptoms of any toxin or venom that's been injected into you. Pit vipers are found throughout the U.S. A lot of them here. I think all three types live here. We talked about that they've got the noticeable fangs, the very like hypodermic needles that are designed to go in and hook in. They've got very potent venom. They're designed to kill big animals so they can eat them, but they'll kill you quick too. A lot of times it's you get bit because of stepping on the snake or just being near the snake. Did you probably heard about this, about the guy that he was up around your area that got bit by the snake head. He found a snake and killed it, threw it in his cooler, cut his head off, threw it in his cooler, reached in his cooler a little bit later, forgot it was in there, and it actually locked onto him. And I mean, it didn't kill him or anything, but it was from up around your area.
They got these kits now at the academy. It's called the Extractor, and there's a guy that actually used one of them and it saved his life. It was around here.
Like suck the venom out.
Yeah, you put it on it and it sucks down on it, and then it's a syringe that pulls it out.
I thought they were saying that should cause more damage.
You look less tissue there.
It's not something we're going to do in pre-hospital setting, but if you're out in the wilderness,
They're only like $10 to get them.
used to they used to say if you get bit, suck out the venom. Not going to do that either. Anyways, we got to keep going. You may have localized or systemic effects. If it gets into the bloodstream, then it's going. Not all the bites are envenomated. I think 25%. I think it's 25% of the bites are not envenomated. There's a higher number that they are, but anyways, the venomous snakes, you got the triangle head, the non-venomous, they're just gonna just keep going. You'll have the fang bite with the venomous, and then you'll actually have like teeth mark bites for the non-venomous. This is just all necrosis and tissue damage from snake bites. Pretty bad, pretty bad.
Is that from untreated, I mean, just treated, you know?
Well, no, I mean, they're all in the hospital here. They're just, I mean, that venom just, they got a good dose of that venom and it spread pretty rapidly, you know. Even when they're treated, you know, they'll have to get the anti-venom then, and even, you know, it depends on where you live. Like, we had several snake bites, rattlesnake bites come into the unit last summer, and we didn't keep a constant stock of anti-venom, and so we had to have it delivered from Columbus or Montgomery. So, you know, you're talking about at least a good hour before it gets there, and so,
It's expensive too.
yeah. Weakness, chills, diaphoresis, all the same stuff that we've been talking about. With snake bites, you do not want to place the constricting bands because there's already going to be a lot of tissue necrosis, and this is going to cause further tissue necrosis. That's what the venom is designed to do, is to cause necrosis of the tissue. Don't put ice on it either. Don't elevate the extremity because it's going to just pour that venom into the core of the body. If I get bit on my hand and I raise it up, what's happening to the blood? It's draining into my body. Establish IV access, transport to the facility that has or can rapidly obtain the anti-venom. I'm trying to think. I don't think really any of your smaller hospitals, none of them are really going to have it. They're going to, you know, if it's up around your way, you know.
Too expensive.
Yeah.
Shelf life might not be that long.
Yeah. If it's up around your way, I'd imagine they'd either call Birmingham or Montgomery to try to get some.
I think they discontinued the anti-venom for coral snakes because there's less than 22 bites a year. So
Really?
it's expensive to make.
Another bit of information that I'm glad I have now.
Well, thank you, doctor.
It's pretty interesting though. Coral snakes are found mostly in the southwest. They're not pit vipers. They've got the backwards oriented fangs. That's designed for them to bite in and hang on. All right. How do they tell the difference between a coral snake and a king snake?
Red on blacks, it's red to jack.
Red on yellow is
Yellow
another.
fella.
Kill a fella, yep. A lot of times they will resemble just a harmless snake, but that old red on black, venom black, red on yellow, kill a fella. Venom's a very potent neurotoxin. We know what a neurotoxin will do. Messes with the neurosystem. Like Dusty said, the bites are very rare. Maybe delayed signs and symptoms, but they'll probably know that they've been bit by a snake if they get bit by a snake. You may want to put a compression bandage on. What's the difference in a compression bandage and a constricting band?
Puts equal pressure.
Yep. Compression bandage is an ACE wrap. It's going to wrap up and it's going to compress that area. Constricting band, you know, is just going to constrict the vessels. All right, let's stop there for now and go take lunch. All right, so we're going to get back into the venomous animals. The marine animals. What are probably the most common that we would experience, like on the Gulf?
Jelly and the,
Oh, jellyfish,
Stingray.
and the, what's the?
Stingray.
Stingray.
Yep. I've seen a bunch of stingrays and I've seen a bunch of jellyfish down at like Orange Beach, Gulf Shores area. They will, and you know, it's usually, as far as like jellyfish go, it's usually not enough to to kill you, you know, but it's going to cause a really bad day for you. And then the stingrays, heck, the old crocodile hunters, that's what killed him.
It
Yeah.
hit him like
Got him in the heart.
right in the heart.
Yeah, that barb got him in the heart.
He hit it, then he pulled it out, and that's the blood he did.
I don't know what happened, but nonetheless, he got it.
Pulled out. Three days. He went in and pulled it
Yeah,
out.
pretty.
Severe cases of marine animal toxicity or poisoning, nausea, vomiting, diarrhea. You know, it's just not going to be a good day. There's some jellyfish in Indonesia, in Australia. That's where like the man of war lives. The
big one.
big jellyfish is it'll take you out. Looks kind of like the jellyfish that's on the old Mario games.
What's that guy? Jack Canna?
If it's a saltwater bite, it's going to be flushed with saline, isopropyl alcohol, or vinegar. The stingers, and even not just with venomous or stinger marine animals, but even with stingers with like bees and wasps and stuff, especially bees, they've got that sharp hypodermic needle, and when they go in, it breaks off. They don't need to be grabbed with tweezers, because when you pinch with the tweezers, you actually can inject more toxin into the body.
Pushing the poison.
Right. So the best way to get them out is going to be with scraping motion with a credit card, or something like that. The jellyfish, they've got all those little things on them, and I think that's what they're talking about, the nemocysts. It's not just one stinger. It's a whole bunch of them that lodge into the body. I don't really see us dealing with any of that in this area, but who knows? Some of y'all might go down south, and they will test you on this. You want to put heat on it because it inactivates the venom and relieves the pain. You may be tempted to put ice on it when you start seeing swelling and stuff, but you actually want to put heat on it. In severe cases, when you start seeing shock symptoms, you could try to put a loose constricting band on, and it may slow the distribution of the venom. And again, in most cases with marine bites, they'll be able to, or not marine bites, but any type of animal bite or sting, they'll be able to tell you, unless it's like a spider, a brown recluse, or something like that. Always be aware of infection risk with any type of bite. Now we're going to move right along into over-the-counter medications. This section we're going to talk about prescription and over-the-counter medications. And after we get done with that, we're going to move into really quick street drugs. The thing about over-the-counter medications is that folks don't realize exactly how harmful or damaging they can be, and they're very easily available. Tylenol, aspirin, over-the-counter cold medication. They don't realize that if they're overdosing just to make a point on Tylenol, that they are really hurting themselves. Tylenol is one of the most common intentional overdoses in younger people that aren't necessarily trying to kill themselves. You see that a lot with people that are trying to make a point across, trying to get some attention. Now, I'm not saying they're being like attention hounds, like Facebook and all that, but they need help. This is their way of crying out for help. And so they do this just so that they can show they've got the potential to do it with something a lot more deadly, but this in fact could be deadly. It really hurts. It really hurts the liver. It is one of the most widely used pain relievers, and it is an analgesic and an antipyretic. It is not a non-steroidal anti-inflammatory medication. Most of the time the overdose is asymptomatic, but within 24 hours, if it's bad enough, they'll start getting liver failure. This N-acetylcysteine is also called Mucomyst. That's the antidote for Tylenol overdose. It's Mucomyst. Mucomyst goes in and absorbs it. It smells like rotten eggs, and it's injected IV. It's not anything we would do in the field. Aspirin. What is the biggest problem about aspirin overdose? I just gave you the answer. Well, it's in the name. Salicylic acid. If you take too much of it, acidosis, right? Well, kids, it's Ray's syndrome or Rise syndrome. A lot of people are on it, and we talked about it when we talked about cardiology. A lot of people are on aspirin as a daily regimen. A lot of times, folks become toxic from aspirin because the regular doses accumulate. In order for it to be toxic, it's got to be 300 milligrams per kilogram, which is a good bit of aspirin. If you think about normal home regimen, folks are on baby aspirin, which is 81 milligrams, one tab. You know, it takes 4 tabs to get 325 milligrams. Now, the Bayer aspirin, the enteric coated or the big aspirin, they're 325. But if you figure somebody is, you know, a 200-pound person is 100 kilograms, they're going to have 3,000 milligrams for it to be toxic. So it's still a good bit of pills. When you become toxic and acidotic, it's going to be the same processes as any other acidosis, which impairs your energy production in your cells. Some of the things that you will see: GI distress, ringing in the ears, which is called tinnitus, hyperpyrexia, which is what?
Fever.
Yeah,
High fever.
high fever, very high fever. And in some cases, dysrhythmias, heart failure, or pulmonary edema. Antihistamine overdose. Antihistamines have anticholinergic properties. What does the anticholinergic do?
Dries you up.
Yep, it reverses the cholinergic effects, right? Cholinergic effects, you start pouring out. Anticholinergic is going to dry you up. You'll see some of the same signs and symptoms as you would if they had taken any other anticholinergic. Dried up, blurred vision, tachycardia, things like that. Iron. People take iron supplements, and when they're done taken at a normal dosage, it's okay. But too much iron is very toxic. Small children is one of the big areas that you'll see iron toxicity.
I think they said the body can only absorb 4 milligrams of iron a day.
Yeah, it's not a lot. It's not a lot. A lot of GI issues. The big thing with iron is that it interferes with cellular energy production. You'll see acidosis, you'll have oxygen exchange issues, and then you'll start seeing liver, heart, the vital organs are damaged. Now again, we don't have to get real deep into this stuff, so that's why I'm kind of moving on, but if you've got a question, let me know. Benzodiazepines. Well, we're going to talk about prescription medications. Benzodiazepines are what?
Antidepressant.
Not antidepressants. They're sedatives. Valium, Ativan, things like that. Sedative hypnotics are medications like Ambien. Narcotics, we know what narcotics are, right? Hydrocodone, oxycodone, OxyContin, morphine. Your antidepressants, there's several classes of antidepressants. That's going to include stuff like Celexa, Wellbutrin. Your psychotropic medications, that's going to include medications like Abilify, Haldol, things like that. And then your cardiac medications, your beta blockers, your cardiac glycosides, like we talked about a little bit earlier. So we're just going to briefly hit on each of these. Benzos, they are given to treat anxiety, and they're given to help people sleep. Usually folks don't die from benzo overdose, but they can. If they take enough of these CNS depressants and all that, it's going to cause them to not breathe. The main things you're going to see with really any of these is going to be altered mental status. Well, with any of like the benzos or the NARPs and all that, and respiratory depression. Narcotics, talked about the opiates. There's also synthetic and semi-synthetic narcotics. Those are called opioids. They're controlled substances, which means that they have to be prescribed by a doctor, and the doctor has to watch those prescriptions. A lot of your maintenance medications, your heart medications and things like that, they can give you refills on your medications. They can't on controlled substances. Once that month is up, you have to call back and get another prescription. Lots of CNS depression, respiratory depression. Those are our two main things with opiate overdose. And the reason why I talk about that a good deal is because we can treat an opiate overdose, right? With what? Narcan, right. When we give Narcan, are we wanting to get them completely awake? We're wanting to...
Stimulate respiratory drive.
Right, we're wanting to stimulate respiratory drive. All right?
Barely keep
We,
them on the edge.
right, we want them to be in... and it's not because we want them to be asleep. It's for their own good. If we totally reverse the actions of those opiates and they wake wide awake while their body...
They're going to for benefits.
Exactly. Their body's going to start withdrawing. They're going to freak out. They're going to have a lot of issues. Now, what was important to remember about giving Narcan?
It's slow push, 1 to 2 milligrams IV.
Okay, all right. But what does it do on the cell?
It attaches to the opiate receptors.
Right. How long does it last in your system?
Very short time.
Not as long as the opiate does. So we're going to have to
Put more in every
We're going to have to continue to watch.
10 to 15.
We're going to have to continue to watch it. And even if we give enough for them to wake all the way up, it doesn't knock the opiates out of the body. They're just kind of floating away, floating in the bloodstream, and once the Narcan's gone, it's going to come back and get its piece of action, all right? Other medications that depress CNS function, we've already talked about alcohol and then barbiturates, which are medications that are used to treat seizures. And again, you'll just see the same things that you see with any other CNS dysfunction. Death can occur because if we're depressing the nervous system, we're depressing the respiratory system, we're depressing the cardiac system. Your antidepressants, these are usually given for severe depression, suicidal risk, that kind of stuff. The thing about antidepressants, though, yes, and it's not necessarily that the medication itself is causing depression, but when they take it, when you normally take a medication, do you take it after you feel better?
You
No.
become very non-compliant to our medication.
Right. And so that's the problem with depressive medications. Once they start feeling better, oh, well, I feel better. I don't want to take this medication. I'm embarrassed that I have to take this medication. I don't want to take it anymore. So once they stop taking it, that's really when the suicide risks hit again, because they feel good enough to do something about their depression, as far as like knocking themselves off. Now, and a lot of times the suicide risk is greater in adolescents when they take antidepressants and even when they're on the medications. You got cyclic antidepressants, MAOIs. If you ever pay attention, and you'll pay attention the next time you watch a commercial that talks about medications, at the very end when they're giving all the warnings and stuff, they always say should not be taken with MAOIs. That's what they're talking about. These medications, and again, I can't get down to the very depths of it and all that, but these medications interact with tons of medications. It's a very old form of medication, And if they take a medication and they're on this medication and they interact, it's not a good thing at all. SSRIs, selective serotonin reuptake inhibitors, that's like Celexa. And then these others. The names of them, the types of them really don't mean a lot to us, other than the fact that they're on antidepressants. Now, one of them though, however, a tricyclic antidepressant, they're older antidepressant, but they can have the most drastic effects when overdosed. They can cause confusion, hallucinations, hyperthermia, all these things you see here. TCA overdose could be pretty bad. MAOIs, the ones I was talking about, interact with certain drugs and stuff. They also interact with foods that contain tyramine. And if you decide to go to medic school and nursing school, they'll talk a lot about that stuff. Serotonin syndrome is an effect of overdosing on some of these medications that stimulate serotonin in the brain. Serotonin is one of the medications that, or not one of the medications, but one of the chemicals in the brain that helps you sleep. So they'll have a lot of these issues you see here, especially sleepiness and things like that. Antipsychotic medications called neuroleptics. They affect the neurosystem. Sedatives and some antiemetics as well. These patients that may overdose on antipsychotics or get too much of that medication in their system, whether intentional or non-intentional, they may suffer what's called neuroleptic malignant syndrome. One of the big things about neuroleptic malignant syndrome is hyperpyrexia. These people spike a fever 103, 104. It's not because they've got an infection, but it's because it sends their body into hypermetabolism. Again, just scrolling through these. I'm not expecting you to know all this stuff like the back of your hand. The other stuff I want you to know. Lithium, bipolar medication. Toxicity can easily occur with this. And remember when we talked about medications, the therapeutic range? Anything on the low end, we found that medications have a certain dose that they're effective at, and then they have a certain dose that they're dangerous at or they're toxic at, and in the middle there is the range of where you've got to give the medications. And some medications have a wide range. They can give, you know, it can be several milligrams, 10, 20 milligrams before it gets toxic. Something like lithium, I mean, it's a matter of just half of a milligram could be toxic. What do you think would be some of the issues with somebody that overdosed on cardiac medications?
Yeah.
Dysrhythmias,
Like PAD or PDA.
PDA, yep, some of the cardiac conduction issues. Also,
Wouldn't it be a depressant?
well, it depends on what kind of cardiac medication they take. If they take like a beta blocker, if they overdose on beta blockers, their veins are going to open wide up. They're going to become very hypertensive. Heart rate's going to slow way down. Most of the time, folks aren't going to overdose on cardiac medications on purpose. It's not going to be intentional overdoses. Who do you think is going to be the ones that overdose on cardiac medications?
Old people.
Older people, the elderly, that have forgotten they've taken their medication, or might have forgotten they've taken their medication several times that day, or just feeling funny and feel like they need to take another medication.
Wait, could you go back one?
Beta blockers and calcium channel blockers. Beta blockers, we just talked about, bradycardia, hypotension. Calcium channel blockers, calcium has a lot of effect on the electrical conductivity of the heart, so it might give you some arrhythmias. Digitalis, it controls the heart rate and strengthens cardiac contraction. Dig is another medication that has a very small therapeutic threshold or therapeutic dose range. There's a couple things that are kind of specific to digitalis overdose. This blurred vision or yellow-green vision, everything kind of has a yellow-green haze over it. The digitalis affects a lot of vision issues. So if they're on cardiac medications and they start saying that they're having a lot of vision issues, you might suspect that they've had a digitalis overdose. Just recapping on what we said, not all patients with narcotic overdose requires Narcan. We only give Narcan if they what?
They can't breathe.
If their respiratory drive is depressed. And it's just saying everything we just talked about. Street drugs, quickly. Stimulants, cocaine. This is a stimulant that's going to affect which nervous system? The sympathetic. Right. Inhaled in the powder form, that's cocaine. Once it starts getting as the liquid, well, I guess that would still be. But crack is smoke. Crack is a cheap version of cocaine, and it's smoke. And that's bad. I forgot what the number was, but I heard it was like maybe 80 to 90% of any dollar bill passed through currency in America right now has residue of cocaine on it.
Yep.
It was a very high number. The thing about cocaine, the effects are immediate, and then they go away, so they need more. They start feeling euphoric, energetic, and alert. They lose weight. They don't need sleep. But the problem is that it's short-acting, and they start tweaking. They start having a lot of issues.
Cocaine is a drug of abuse. Cocaine blocks the normal reuptake of neurotransmitters, like dopamine, into the originating presynaptic neuron. Thus, instead of the regular propagation of an action potential across the synaptic cleft, cocaine causes the prolongation of the neurotransmitter effects, which through repetitive stimulation of the postsynaptic neuron causes the reward centers of the brain to be overstimulated, leading to dependence.
Basically, that was saying that it blocks the normal function of the uptake of the chemicals in the brain. The reward centers of the brain, the areas that make you feel good, euphoric and all that, they're overstimulated, and it makes you feel good until it wears off, and then you start having a lot of issues. So if it's a stimulant, it's going to be a vasoconstrictor. It's going to cause, a lot of agitation, irritability, especially as it starts wearing off and they need more. The big thing about this, though, one of the first cardiac arrests that I worked was a person that had taken way too much cocaine, and it stimulated their heart so much that they went into VTAC. Now, it's a relatively easy code to work because you can usually get them back. Because usually they don't have anything necessarily wrong with their heart other than the overstimulation of it. But that's very common. You may get called, and it's not far-fetched to get called out to a scene of a person that was running from the cops and then swallowed a bag of cocaine. Once that stuff busts open in their system, it's bad news. Bad news. I think y'all seen that picture before, haven't you? It's my drugs having recreation. Amphetamines. Now, amphetamines are on the street as a legal form of medication used to treat ADHD or ADD. Folks that you may not ever think would take it, and the folks that you think might need to take it, don't take it. Anyways, these kind of medications and diet pills and all that, the reason they're a safer form of an amphetamine than methamphetamine. And basically, diet pills, it uses those effects of amphetamines that make you not hungry. ADHD medication, like Adderall or Vyvanse, those kind of medications, they're designed to help you focus and help you, it's kind of crazy. A person with hyperactivity is going to take a stimulant medication and it actually does the opposite effect of what it normally would do. Folks with ADHD that don't take medications actually drink a lot of times drink a lot of caffeine because it actually medicates them. It's self-medication. Methamphetamine is the illegal form of it. And it's bad news too. A lot of times you'll get excited delirium from that. And remember, delirium that's induced by medication. And there's no reasoning with them. PCP, it's a dissociative anesthetic. And when they say dissociative, you are disassociated from the rest of the world. You have no clue where you're at. It has a hallucinogenic effects. That's why most people take it. All the things you see there for overdose, they're at risk for excited delirium. And again, this is where it just overstimulates the sympathetic nervous system. These patients, though, you're going to need to get law enforcement to help you because you're not going to be able to control them yourselves. LSD, it's acid, street name acid. Fatal overdose is extremely rare, but it will make you do some crazy things. Mescaline and all these others, you can go back and review those. What are some things that we may look for that might be signs of IV drug use?
Marks on your arm.
Track marks, right? I'm not going to talk about the narcotics again. What street drugs do you think we have a lot of around here?
Meth.
Meth and what else? All right. If you get closer to the university, you're going to see illegal prescription stuff taken, lots of Adderall, lots of stuff like that, but also roofies, pain medications. You get into more of the inner city, ghetto kind of places, you're going to see a lot of crack cocaine use as well. Out in the rural parts,
See meth with the college girls, students.
they're going to get a hold of Adderall and things like that because it's going to, it's going to have a lot of the same desired effects, but it's going to be a little bit safer, but it's still dangerous. Out in the rural areas, you'll see your meth, where they can cook it up real good. You got some that will make it in the city as well, but y'all can go back and look at all these other drugs of abuse. All right, so that was a very, very long lecture.
Yes, it was.
Are there any questions?